Hi everyone, this is Dr. Nickpon, and this PowerPoint is going to be focusing on the abdominal assessment, both GI and GU. So there is quite a bit of content in here. I did use your text as our outline, so you'll see this PowerPoint and the text really go along with each other, so you can use them to supplement one another. So the abdominal contents, it is our abdomen is inferior to our diaphragm and superior to our pelvic floor. Those are the upper and lower borders of our abdomen. It is framed by costal margins of 7, 8, 9, 10, and 11th rib. And then we have bony landmarks of the right and left iliac crest and the pubic tubercle. So the next slide, I actually show that where the anatomic borders of the abdomen is. The content of our abdomen includes our GI tract, organs that aid in digestion, and abdominal structures of other systems. We do have a lot of musculature in the abdomen. This helps to protect organs and structures. There are two layers. The innermost are the internal obliques and transverse abdominis muscles, and the external layers are the external obliques and the rectus abdominis. So this is a slide showing the surface abdominal landmarks. So you see where the iliac crest, pubic tubercle are, the symphysis pubis. We are below the level of the diaphragm, just to give you an idea of the area that we are going to be talking about during this PowerPoint. The abdomen is also divided into quadrants. So there are 4 quadrants of our abdomen. You'll read about that. I'm sure as nurses, you document that. We have our right upper quadrant, our left upper quadrant, our right lower quadrant, and the left lower quadrant. And the umbilicus is right in the center for most people. And so this is very important. Later on in the PowerPoint, we're going to be talking about different conditions that can happen in each of these quadrants. Along with the quadrants, we have abdominal regions, and I have them listed here. There are actually 9 regions, and in a few slides, there will be possible diagnoses when patients present with pain of certain regions. So abdominal pain is any discomfort in the mid region of the anterior torso, so in that abdominal region, and it is a common reason for our patients to seek care. It can be very difficult to determine the cause. So some common diagnoses that we can see with abdominal pain are non-specific abdominal pain, where we just never know what really is causing it or caused it. Acute appendicitis, acute cholecystitis, small bowel obstruction, and other diagnoses that we can see are gastroenteritis, gastritis, GERD, IBS, diverticulitis, and there are many more. These are just some of the most common diagnoses you can encounter in primary care. There is also a possibility of referred abdominal pain, a referred pain to the abdomen from other parts of the body. Abdominal pain can be functional, it can be organic, it can be acute or chronic. It may be life-threatening in the case of small bowel obstruction, peritonitis, untreated appendicitis, or it could be non-life-threatening. So knowing anatomy is very important. Here's the slide I was talking about a little earlier about differential diagnoses according to locations, or localization of the abdominal pain into one of the 9 regions. So differential diagnoses, you're going to hear about this more and more as you proceed through the program. So we have a patient presenting with abdominal pain. What are our differentials for that patient? What are the possible diagnoses that we are thinking of? And that's always important that we are giving some consideration and not just zeroing in on one diagnosis, because there are possibilities and we need to rule out and rule in the diagnoses in order to give the best care we can to our patients. This is just another slide, very similar to the last one, just showing those 9 regions and possible differentials for them. So now we're going to go through a little review of our GI tract, talk a little bit more about the anatomy. And the GU tract. The GI tract includes the whole passage along with which food moves from our mouth to our anus. That is also called the alimentary canal. There are accessory organs that are attached to the alimentary canal, which are liver, gallbladder, pancreas, and our appendix. Our appendix is included in here. Although it does not aid in digestion, it can play a role in the diagnoses. So the mouth and the esophagus begin the alimentary canal. We have intake of food, we chew our food, and then physically we start breaking it down. Food passes down the esophagus into the stomach. The esophagus is actually not in the abdominal cavity, as that is above the level of the diaphragm. So remember, in the previous slides, we talked about the abdomen being below the level of the diaphragm. Food moves through peristalsis into the stomach, and the lower esophageal sphincter separates the esophagus from the stomach. And you can see in the photo on the right where that lower esophageal sphincter is. That should be closed. You'll see later in some slides where we talk about possible abnormal functions of the GI tract, and especially with GERD, sometimes that esophageal sphincter is not functioning well, allowing some of the stomach acid to get into the esophagus. So our esophagus has normal pH and our stomach has a lower pH, so we want to keep the contents of the stomach in the stomach. So low or poor pressures can lead to GERD. In the stomach, we have actually, the stomach extends from the lower esophageal sphincter to the pyloric sphincter. It is a sac-like structure, and the purpose is physical and chemical digestion of food. So it mixes food with digestive juices and acid. And actually, now we aren't even going to call the food food anymore. We're going to call it chyme. Chyme leaves the stomach through the pyloric sphincter and now enters the small intestine. The small intestine job is to further facilitate digestion and absorption. It has three segments. It has the duodenum, the jejunum, and the ileum. The length is 18 to 21 feet. And within the lumen are villi, which increase the digestive surface of the small intestine. Through coordinated neuromuscular innervation and peristalsis, chyme is propelled through the small intestine. In the three different portions of the small intestine, we see different things happen. So in the duodenum, bile and digestive enzymes are secreted, promoting digestion of fats and starches. In the jejunum, chyme flows here and absorption of nutrients occurs, such as minerals, electrolytes, carbohydrates, and fats. And in the ileum, we see the absorption of B12 and bile salts. The terminal ileum and ileocecal valve mark the end of our small intestine. The ileocecal valve controls the flow of chyme into the large intestine. In this area, we can see terminal ileitis, which is inflammation of the terminal ileum, Crohn's disease, which is an inflammatory bowel disorder, which I will talk about a little later in the PowerPoint, often affects the ileum and the terminal ileum. This is just a picture of the small intestine. So you can see the esophagus, our stomach, and then the duodenum, jejunum, and ileum. And then the large intestine actually borders our small intestine. So our large intestine measures about 5 to 6 feet. It has 7 segments. Our cecum, which is very short, it marks the beginning of the ascending colon, and it is on the right side of the abdomen. We have our ascending colon, which ends just beneath the liver and gallbladder at the hepatic juncture, which is the bend. 30% of cancerous tumors are found in the ascending colon. Transverse colon is inferior to the stomach, crosses the abdominal cavity, and becomes the descending colon. Then we have our descending colon, which is on the left side of the abdomen, and it ends with our sigmoid colon, rectum, and anus. The appendix is attached to the cecum, and again does not aid in digestion, but can become inflamed. The large intestine is wider and shorter than the small intestine, and the primary job of the large intestine is to absorb water and electrolytes from chyme and elimination of residual undigested food as feces. The ileocecal valve prevents backflow of chyme into the small intestine. And here are just a few photos showing the large intestine. So on either one, you can see the appendix, that little appendage that's coming off of the cecum. We have our ascending colon on the right side, transverse colon, descending colon, and then the sigmoid colon with the rectum and the anus. The first accessory digestive organ we're going to talk about is the liver, and this is in our right upper quadrant. The liver serves over 500 functions for our body, and it has 2 lobes. Within each lobes are smaller lobes that are called lobules, and lobules are comprised of hepatocytes, which are the main functional cell of the liver. They serve metabolic, endocrine, and secretory functions. The liver processes all blood that leaves the stomach and intestines. So some of the major functions are metabolizing nutrients to produce energy, produce bile, produce immune factors, produce cholesterol, and many types of essential proteins. Our liver also breaks down harmful substances such as bacteria and poison, converts ammonia to urea, removes bilirubin, regulates blood clotting, processes hemoglobin to extract iron, and regulate levels of amino acids. Our liver is protected by the right lower portion of the rib cage, and our liver extends all the way across the abdomen over the stomach. The span is about 2 to 6 inches. And here we have some photos just showing on the left where the liver lies within our body, and the photo on the right showing the different functions that are connected, or the areas that are connected with the liver, including the gallbladder, the cystic duct, and the left hepatic duct. Bile, we're going to talk just a little bit about that. It's not really a digestive organ, but it's something produced in the digestive organs. It's transported out of the liver through ducts. The common bile duct is formed by the junction of the common hepatic and cystic ducts. Majority of the bile, 75%, is secreted out of the liver through the common hepatic duct to the gallbladder through the cystic duct. The rest of the bile drains directly from the common bile duct to the duodenum. Blockage, stasis, infection, and inflammation of ducts can all cause health problems. So this is a photo of the biliary system showing the right and left hepatic ducts, gallbladder, cystic duct, common bile duct, and our pancreatic duct, as well as our gallbladder. Our gallbladder stores bile. It is a pear-shaped sac at the inferior ventral surface of the liver at the right midclavicular line. Its digestive purpose is to release bile into the duodenum through the common bile duct when it is stimulated, and bile promotes the emulsification of fats. Here is a photo of the gallbladder. You can see the liver in the background, and then we have the biliary system that we've already discussed. The pancreas is it's a 6-inch long thin gland below the stomach, and its 2 purposes are to produce digestive enzymes and secrete these into the duodenum through the pancreatic duct. That makes our pancreas an exocrine gland, and production and release of insulin is an endocrine function, so it's also an endocrine gland. The common bile duct and pancreatic duct join and release their digestive products into the duodenum through ampulla of Vater, and this is controlled by the sphincter of Oddi. And here are just a few photos showing the pancreatic duct on the left, along with other organs in the abdomen, and then the photo on the right really just zeroing in on the pancreas as well as biliary system. Next, we're going to talk about the urinary system. So this also lies within the abdomen. Included in the urinary system are our kidneys, ureters, bladder, urethra, and the renal circulatory system. The primary function of our urinary system is to filter waste, toxins, and foreign materials from the bloodstream. It is a sterile system. Our kidneys prevent accumulation of nitrogenous waste. They balance fluids and electrolytes, assist in maintaining blood pressure, and play a role in erythropoiesis, which is production of red blood cells. This is a photo just showing the anatomy of our urinary system, and this actually shows the circulatory system along with it. Our kidneys are bean-shaped in the retroperitoneal space, and they're protected by the 11th and 12th ribs at the costovertebral angle between T12 and L3. The left kidney is slightly higher than our right kidney, and that has to do with our liver being there. The adrenal gland lies on top of each kidney. Each kidney is made up of 1 million nephrons, and nephrons are really the functional unit of the kidneys. The nephrons contain glomeruli, which filter the blood, and tubules to excrete waste products and return filter blood to the circulatory system. Each kidney has a renal artery, which perfuses the kidney, and a renal vein, which returns the filter blood to the circulatory system. And here are some photos on the left showing normal kidney anatomy, and on the right, just showing you a magnified view of the nephron that is within the kidney. After blood is filtered, waste products, excess water, and electrolytes are excreted by the nephrons in our urine and eliminated from the kidneys through our ureters. Urine flows through the ureters with peristalsis to the bladder. Each ureter is about 10 to 12 inches long. And I did include this slide showing the male and female urinary systems. So the big difference is you can see the female organs, our uterus, fallopian tubes sitting on top of the bladder of our female patients. And then in our male patients, we have the prostate that is surrounding the urethra. So our bladder is a reservoir to hold urine before we urinate or micturition. It is a hollow vascular or hollow muscular organ. It lies on the pelvic floor above the symphysis pubis, and it does have two parts, the rounded muscular sac composed of detrusor muscle and the urethra. The detrusor muscle allows urine to collect in the bladder and then contracts. When empty, the bladder is low in the pelvis, but when it is full, the bladder fundus is palpable. In males, that prostate encircles the neck of the bladder, and in females, the bladder lies anterior to the vagina and uterus, as we saw in the previous slide. The urethra is a single tube-like structure. It is mucus-lined. The length is 1.5 inches in females and 20 inches in males. So you can see there is a big difference between the length of urethra. The urethra ends with the urethral opening, the short length of urethra in women, and the proximity to the anus allows for easier bacterial contamination in women. The spleen is an organ of the immune system. It lies in the left mid-axillary line, as you can see from the photo on the left. It is fish-shaped and about 4 inches long. Its functions are to filter blood, removing old and damaged red blood cells and old platelets. It stores breakdown products of red blood cells and lymphocytes and returns red blood cell breakdown products to bone marrow and helps to fight infection. It stores blood that can be released if there is significant blood lost. So some lifespan considerations are organs in the abdomen grow in size, function, and dysfunction over the lifespan. For instance, with our infants, the stomach changes from horizontal to more of a vertical position. Appearance of the abdomen, infants have less abdominal tone. Older adults begin to lose some of that musculature. Changes in dietary intake affects the abdomen. Pregnancy induces changes, and aging affects kidney size and function as well, just to name a few of the changes that we see throughout the lifespan. History of present illness, or your HPI. Common complaints that we will see when patients come in are abdominal pain, nausea, vomiting, constipation, diarrhea, and incontinence. It is very important that you use our old CARTS system, and our text does a wonderful job breaking down these different complaints and important questions to ask. Also, there are differentials listed in your text as well as in some of the beginning slides in this PowerPoint. Red flag symptoms. There are a few symptoms when patients come in with that we need to address pretty quickly, and these include if they have GI symptoms with arthritis, if they have bilious emesis, deceleration of linear growth, delayed onset of puberty, dysphagia, hematuria, hematemesis, hepatosplenomegaly, nighttime pain or nighttime diarrhea, oral ulcers, family history of IBD, Lynch syndrome, celiac disease, or hepatobiliary disease. If your patient has perianal skin tags and or fissures, persistent right upper quadrant or persistent right lower quadrant pain, persistent vomiting and diarrhea, recurrent and unexplained fever, rectal bleeding or melena, severe flank or groin pain, unexplained anemia or weight loss. In the medical, family, and social history, we need to get a thorough and accurate history. This remains a top priority. Social determinants of health are very important. So sometimes I'll have students ask, well, why are we asking all these personal questions to our patients? And we really need to know, financially, are they able to buy food that they're supposed to be eating? Do they have celiac disease and can't afford the gluten-free options? Do they have a safe place to live? All of this plays a big role in your patient's health. So making sure that we're getting a thorough medical, family, and social history is very important. Our physical exam is a little different order than our other body systems. So with our abdominal exam, first we're going to inspect, then we're going to auscultate, listen around in the stomach, then we're going to percuss, and lastly, we're going to do palpation. And we save the palpation for last because this may induce some pain. So before we do our abdominal exam, we want to make sure that we are prepared for it, that we have good lighting, because we need to be able to visualize the patient's skin of their abdomen, look for any bruising, ecchymosis that may be there. We want to make sure the patient is relaxed, so the room is at a good temperature, that the patient's adequately draped, that their arms are at their sides with their knees bent. The purpose of this is just to relax those abdominal muscles as much as possible. And we want to make sure that our hands and stethoscope are warm so that when we physically touch the patient or when our stethoscope does, it doesn't cause that muscle contraction from being cold. So the first thing we are going to do is inspect, and this is strictly observation. So we're going to think about the underlying organs. We already talked about the importance of appropriate lighting so we can evaluate skin characteristics and color. Are there any scars indicating previous abdominal surgeries, bruises, discoloration, lesions? Where is the umbilicus? Is it midline without hernia or nodules? What is the contour of the abdomen? And contour is either described as flat, scaphoid, rounded, or protuberant. In the next slide, I show photos of what these are. And the contour of the abdomen is associated with nutritional status, gas, enlarged organs, masses, or fluid. When we are doing our inspection, we want to go side to side and up and down, looking for symmetry and contour. Have the patient take a deep breath and hold it, and then raise their head off of the exam table. What this does is to help lower the diaphragm and moves the abdominal organs downward so we can better assess if there's any bulges or masses in the abdomen. The contour should remain smooth and symmetric. Raising the head contracts the abdominal muscles, allowing for assessment of previously undetected masses, bulges, or nodules. And these are the 4 photos just showing what is considered flat, rounded, scaphoid, or protuberant when we are talking about the contour of the abdomen. So I did mention the possibility of ecchymosis, which is an ominous finding, meaning that your patient may have had trauma or hemorrhage. It's a possible sign of pancreatitis, ectopic pregnancy, or hemorrhage, but it is a controversial sign. Gray-Turner sign, which is flank ecchymosis, and Cullen sign, which is umbilical ecchymosis. Also a Sister Mary Joseph nodule, which is an umbilical nodule. It can be an initial sign of malignancy or a metastatic sign. Jaundice and abdominal venous pattern. So this has various etiologies involving the liver. When you do see this, it's suggestive of hepatocellular disease, especially if it's combined with palpable spleen, liver, ascites, spider angiomas, palmar erythema, and dilated abdominal veins. So Cullen sign, this is that ecchymosis surrounding the umbilicus. And Gray-Turner sign, which is the ecchymosis of the flank. The Sister Mary Joseph nodule, and a photo of jaundice. The next part of our physical exam is auscultation. So bowel sounds really have limited value as an accurate diagnostic tool. However, it is one of these things that we still do. And we want to listen for vascular sounds and bruits. So turbulent blood flow is associated with vascular disease. Bruits over the aorta, iliac, renal, and femoral arteries normally are not heard. Abdominal bruits during systole in the epigastric region are normal, but continuous bruits across systole and diastole are concerning and do require additional workup. Bruits are heard away from the midline are concerning and also need more workup. Friction rubs may be heard over the liver or pancreas due to inflammation of peritoneal surfaces. And bowel sounds, usually they're categorized as normal, hypoactive, or hyperactive. Percussion is the next part of the exam, and this is helpful with assessment of the size, density, and location of abdominal organs and structures. It can also detect fluid or air in the abdomen. To percuss, you place the distal joint and tip of finger of the non-dominant hand firmly on the abdomen, and you're going to avoid the ribs. Do not place any other portion of the hand on the abdomen. Then you will use the middle finger of the dominant hand to strike the interphalangeal joint of the stationary finger on the abdomen. You want to use short, quick motions, listening for the tone that's produced from vibration of underlying organs and structures. First, you will percuss lightly in all 4 quadrants of the abdomen. Generalized tympany can be found due to gas over the majority of the abdomen, and dullness is heard over fluid masses or distended bladder. And I did include a couple videos here, which are both, I think, less than 5 minutes. One is with abdominal percussion and one showing abdominal percussion and then specifically the liver and spleen percussion. I do recommend that you take a look at these. Percussion of the liver helps to estimate the size of the liver. However, it can be inaccurate due to the technique that is being used. Enlarged livers due to hepatitis or ascites may be easier to detect than normal liver size, and breast tissue can interfere with percussion of the liver. The normal liver span at the right midclavicular line is typically between 2 to 5 inches or 6 to 12 centimeters. Dullness is heard with percussion over the liver. You need to determine both the upper and lower borders. So typically it's recommended you start at the upper midclavicular line over an area of long resonance and percuss downward at interspaces between the ribs, listening for a change in the tone from resonance to dullness. And then you're going to mark that upper border. It's typically near the 5th intercostal space. Then we want to find the lower border. So we're going to percuss at an area of tympani on the abdomen at the right midclavicular line and percuss upward, noting change from tympani to dullness. And we are going to mark this spot and measure the difference. This will give us our liver span. Liver tenderness can be elicited using indirect fist percussion, placing the left hand on the lower right rib cage and then gently striking the left hand with the ulnar surface of the right fist. The liver should not be tender. This has a sensitivity for diagnosing hepatobiliary infection of 60% and a specificity of 85%. Percussion of the spleen, this is very difficult due to where the spleen is located with the stomach and the intestines, and it has limited evidence for use to rule out splenomegaly. However, the technique for it, we're going to percuss posterior to the left mid-axillary line and listen for dullness. Dullness can be heard from the 6th to 10th rib. You may have dullness in Trobe's space, which has moderate sensitivity for splenomegaly. This is the left lower chest area, left 6th rib, left mid-axillary line, and left costal margin. And your text has a great photo of this. Another technique is to percuss the lowest intercostal space in the left anterior axillary line before and after a deep breath. Percussion of the kidneys. Percuss the right and left CVA angle for tenderness. This is indicative of inflammation or musculoskeletal problems. Direct fist percussion can be used or indirect by placing the palm of one hand on the back and striking it with the ulnar surface of the other hand. And then we move on to palpation, the last portion of our abdominal physical exam. This can be used to help assess for masses, tenderness, and fluid in the abdomen. Also, abdominal organs can be evaluated for size, shape, mobility, and consistency. To do this well, our patient needs to be relaxed, so we should have warm hands. We don't want to press too hard, and we have to remember to palpate the painful areas last. So we're going to start with light palpation. We're going to move in a systematic way, palpating all 4 quadrants. We're going to palpate the palmar surface of the hand, or we're going to place the palmar surface of the hand lightly on the abdomen with the fingers outstretched but close together. And for our light palpation, we're going to press down no more than 1 centimeter. We want to keep our hands low and parallel and use a light circular motion. It's important not to drag our hands across the abdomen, actually lift them up and move them to the next space, and the abdomen should feel soft and smooth. Deep palpation, for this we're going to press harder. Again, our goal is not to induce pain, but we want to go down about 5 to 8 centimeters. Again, moving in a systematic way through all 4 quadrants, noting any masses, tenderness, or pulsations. It may reveal tenderness that's not elicited with light palpation. Increased likelihood of peritonitis if your patient has guarding, rigidity, rebound tenderness, percussion tenderness, and pain with coughing. So palpation of the liver, this is difficult because most of the liver is covered with the rib cage. The clinician should place their left hand under the patient at the 11th and 12th rib while pressing up and trying to elevate the liver. The right hand should be placed on the abdomen with the fingers parallel to midline, and using the right hand, push deeply into the right costal margin. The patient should take a deep breath while you're trying to feel that edge of the liver. Hooking technique is an alternative technique, and your textbook does talk about that, as well as the scratch test. Normally, the liver is not palpable. However, in thin people or children, you can feel it. If it is palpable, it should feel smooth, non-tender, and not have any nodules. And this is just a brief slide showing hand placement to palpate. And when your patient takes that inspiration, it pushes that liver down, so you may feel that edge. Palpation of the spleen is done similar to how we palpated the liver. We're going to place the left hand at the costovertebral angle, lifting up the spleen. We're going to place our right hand on the patient's abdomen below the left costal margin. We're going to press our fingers towards the spleen and ask our patient to take a deep breath, attempting to feel the spleen. The hook technique is an alternative, and your textbook does discuss this. Normally, you cannot palpate the spleen. The spleen has to be enlarged 3 times its normal size before it is palpable. And typically, if it is palpable, it's considered abnormal if it's greater than 2 centimeters below the costal margin. And this just shows the palpation technique when we are palpating the spleen. Palpation of the kidneys. We're going to stand at the patient's right side and place one hand on the patient's right flank, the other at the right costal margin, and press the hands together while the patient takes a deep breath. To palpate the left kidney, we're going to reach across the patient and behind to the left flank with the left hand and place the right hand into the abdomen while the patient inhales. The normal kidney edge is palpable, or it is normal to have it palpable or non-palpable. And this just shows photos of palpating both that left and the right kidney. The next area you'll want to palpate is the aorta. So you're going to palpate with the opposing thumb and finger slightly left of midline in the upper abdomen. And there's a nice photo in your text of this. Assess the width of the aorta by pressing on either side of the aorta in the upper abdomen with one hand on each side of the aorta. Ability to palpate aorta is related to size of aneurysm, and inability to palpate aorta is not efficient at ruling out an aneurysm. Normal aorta is 2.5 to 4 centimeters in an adult. Palpation of gallbladder, we shouldn't be able to feel the gallbladder. And if you can, that is abnormal and suggestive of cholecystitis. If it is enlarged, it can be felt behind the smooth liver border in the right upper quadrant, and it feels like a firm mass, as is typically very tender. We have some specialized testing. On this page are all tests that we would use when we are assessing for appendicitis. So we have McBurney's point or McBurney's sign. This is pain with palpation of the right lower quadrant. We have a rebound tenderness or Bloomberg sign. Palpate the abdomen with slow, steady pressure to the suspected area and remove the pressure. It's positive when the pain worsens with hand release. Positive sign can indicate peritoneal irritation or appendicitis. The obturator sign or test is discussed online. However, there is no great research showing its effectiveness, so it's recommended that you use other testings. We're not even going to discuss that further. We have Rosping's sign, which is deeply palpate the left iliac fossa, and it's positive if you have pain in the right iliac fossa, and that may be associated with appendicitis. This shows McBurney's point and Rosping's sign. We have our psoas test, and the patient to do this is in the supine position. You're going to place one hand above the patient's right knee and ask the patient to raise the knee while the clinician applies downward pressure on the leg. It's positive. If it's positive, it induces pain, which may indicate irritation of the psoas muscle due to inflammation of the appendix. There's a heel drop test where you have the patient stand on their toes and abruptly release onto their heels, and it's positive if they have pain in the right lower quadrant. Digital rectal exam is sometimes done with certain GI and GU complaints. And then we have Murphy's sign, which is really used for the right upper quadrant. So if we have concerns about cholecystitis, where you place one hand at the costal margin of the right upper quadrant and ask the patient to take a deep breath, it's positive if the patient has pain. This shows Murphy's sign. There are some lab considerations that we need to think about in our patients who present with abdominal complaints. And I'm going to talk briefly about these. With celiac disease, this is an autoimmune disorder, so antibody tests can be done. And they are listed here, such as the tissue transglutaminase, deaminated gliadin peptide, anti-endomysial, anti-reticulum antibodies, and the quantitative immunoglobulin A. The gold standard, though, is really endoscopy with biopsy, showing shortened or flattened intestinal villi. Inflammatory bowel disease. So this would include our Crohn's disease or ulcerative colitis. They may have some abnormalities of blood testing, including elevated white blood cell count. They may have abnormalities of their electrolytes due to diarrhea. Liver functions may be normal or abnormal, depending on the extent of their disease. They may have low albumin or prealbumin. They could have a positive Hemoccult stool test, positive inflammatory markers such as ESR and C-reactive protein. But again, the gold standard is endoscopy with biopsy. Hepatitis, there are a lot different blood tests for the different types of hepatitis, and that chart is in your Hollier text. Pancreatitis, we will want to check amylase and lipase levels. We typically see amylase rise first and then the lipase rise. They may rise 2 to 4 times the normal values, but we should also do imaging, including abdominal ultrasound or CT. And urinary tract infection or pyelonephritis, which is our kidney infection. A UA would be positive for nitrites. Pyuria and hematuria could be present. Urine culture greater than 10,000, and white blood cell casts on urine culture are really indicative of the upper UTI or the pyelonephritis. Imaging considerations, I did discuss these at different points throughout the exam for some of these through this PowerPoint for some of these diagnoses. Cholecystitis or our gallbladder would be ultrasound and possibly a HIDA scan. For gastroesophageal reflux disease, we would want to consider an upper endoscopy with biopsy or esophageal pH. Appendicitis, ultrasound, CT, MRI. Hepatomegaly, ultrasound, CT, MRI. Splenomegaly, ultrasound or scintigraphy. The next portion of the PowerPoint, which is the last portion, is going to be talking about abnormal findings found in the GI and GU systems. All of the findings discussed here are in your health assessment text. I did try to just pick out some of the key points for each of these diagnoses. So the first one we're going to talk about is constipation, which is slow motility of the intestinal lumen. Common causes include diet, prolonged laxative use, opiate drug use, decreased physical activity, and key findings are dry, hard, small stools, infrequent bowel movements, straining with bowel movements, or the patient saying they feel like they have incomplete evacuation of stool. Diarrhea, which is abnormal rapid transport of chyme in the GI tract. We have increased motility and changes in osmotic mechanisms resulting in abnormal absorption. Triggers can be multifaceted, including bacterial, viral, functional, or organic. Viral gastroenteritis is the most common cause. Most episodes are self-limited and don't need any treatment, but dehydration is possible, especially with high fevers and nausea and vomiting. Many times when people have diarrhea, they have tenderness with palpation of the abdomen. Key findings, with history, our patients report loose, watery stools. We want to assess for possible dehydration. Patients may complain of frequent BMs with cramping, gas formation, and diffuse abdominal pain. It's not typically localized. Nausea and vomiting can be associated with GI infections, functional GI obstruction, central nervous system disorders, pregnancy and metabolic disorders. In adults, the most common causes of nausea and vomiting are gastritis, viral gastroenteritis, psychogenic conditions, or possibly some ear disorders. Other causes could be drug intake or use. Newborns, we could see esophageal atresia or congenital anomaly. History is extremely important with nausea and vomiting. Going through the old carts and your text does a great job with certain questions to ask. Acute pancreatitis is seen with inflammation of the pancreas, and this is where digestive enzymes start digesting the pancreas itself. This can be acute or chronic, mild or severe. Causes are gallstones, biliary disease, alcohol abuse, cystic fibrosis, autoimmune disorders, hereditary conditions and medications. Key history and physical findings. I know your text states that acute pancreatitis presents with right upper quadrant or epigastric pain, but it can also present with pain in the left upper quadrant. This can radiate to the back. These patients can have nausea, vomiting, fever, tachycardia, shallow respirations, postural hypertension, and diaphoresis. Cholecystitis or cholelithiasis is also something that we can see with the right upper quadrant, usually due to occlusion of the bile duct. It may be infection or stone. So when we see cystitis, we should be thinking infection. Lithiasis, we're thinking stones. Most commonly, this occurs in females, and there is a mnemonic of the 4 F's. Female, fat, 40, and fertile. These are the patients that are most commonly affected with gallbladder disease. Key history and physical findings. Acute colicky, right upper quadrant pain with radiation to the back or shoulder. Anorexia, nausea, vomiting, low-grade fevers, increased neutrophils, and jaundice if they do have obstruction. Also in the right upper quadrant, we can see hepatitis, hepatomegaly, and cirrhosis. Hepatitis is liver disease caused by viral infections. We can see liver enlargement, structural changes, and cirrhosis. Hepatitis has different strains, A through E. We can also see patients with non-alcoholic fatty liver disease. This is hepatocellular injury due to accumulation of fat, and it is not associated with alcohol intake. We do see it associated with obesity, dyslipidemia, and type 2 diabetes. Infiltrative liver disease causes increasing firmness of the liver. And key history and physical findings, abnormal liver function tests. However, we can see patients with liver abnormalities and normal liver function tests. So even if you're suspecting liver disease and they have normal liver function tests, they still may need more of a workup. They may have thrombocytopenia, jaundice, hepatomegaly on ultrasound, portal hypertension, ascites, and eventually encephalopathy. Appendicitis is one of the things that we think about when we hear patients have right lower quadrant pain. This is inflammation of the appendix and the most common cause of acute abdominal pain, ages 10 to 30. It is caused by, obstruction of the appendix lumen and then bacterial overgrowth. This is a surgical emergency. It could lead to perforation, gangrene, and peritonitis within the first 36 hours. This can be a difficult diagnosis to make at times, and there are scoring tools available. Key history and physical findings include pain initially vague and by the umbilicus and then migrates to the right lower quadrant. Patients can even have episodes of vague pain and then periods where the pain is gone and then returns and migrates to that right lower quadrant. They can have low-grade fevers, elevated white blood cell count, nausea, vomiting, feelings of constipation, and then some of the special testing that we talked about. They can have positive McBurney's point tenderness, Rossfing sign tenderness, positive psoas sign, rectal tenderness. And these patients, if you ask them to cough or hop, that should induce pain. Strangulated hernia, we can see part of the intestine protruding through a weak spot in the abdominal muscles. It then becomes trapped, causing decreased circulation to the lumen and eventual necrosis. These patients typically have a history of straining, heavy lifting, or previous abdominal surgery. Inguinal hernias are most commonly found, and ultrasound can confirm this. So key findings with history and physical are nausea and vomiting, a palpable mass on abdominal exam. This may turn red, purple, or dark in color. These patients typically have acute pain and fever. Crohn's disease or regional ileitis. We did discuss this a little bit when we were talking about the different portions of the small intestine. So regional ileitis is a disease of the terminal ileum, subacute or chronic necrotizing inflammation. Crohn's disease is autoimmune inflammatory bowel disorder, intermittent exacerbations of mucosal inflammation and ulceration. This really can affect any part of the GI tract and all layers of the GI tract. It can be mild to severe. Key history and physical findings include intermittent cramping abdominal pain. They can have severe diarrhea with blood, pus, and mucus, fatigue and malaise, fever, weight loss, arthralgias, decreased hemoglobin and hematocrit, elevated SED rates during exacerbations. These patients do need colonoscopy, which typically will reveal skip lesions, and many body systems can be affected by inflammatory bowel disorders. Left upper quadrant, we have our splenomegaly or ruptured spleen. This is enlargement of the spleen due to infection, inflammatory disease, and neoplasms, such as hepatitis, endocarditis, malaria, mono, lupus, and leukemia. We can see splenic rupture with blunt trauma or injury, and this is a medical emergency. History and physical exam findings with splenomegaly, sometimes they're asymptomatic or have pain or fullness of the left upper quadrant with fatigue, anemia, and or frequent infections. Key findings of history and physical with splenic rupture are sudden onset of abdominal pain, splenomegaly with left upper quadrant tenderness, hemodynamic instability, confusion, lightheadedness, and dizziness. Perforated colon. This is an opening that occurs anywhere in the intestinal tracts where stool leaks into the viscera or peritoneal cavity. This can occur due to trauma or intestinal injury. Other causes include diverticulitis, inflammatory bowel disease, peptic ulcer disease, strangulated hernia, and toxic megacolon. Swallowing a foreign object can cause this, especially with children. This too is a surgical emergency. Key history and physical findings include gradual and worsening abdominal pain, Ford-like abdominal distension, fever with elevated white cell count, and nausea and vomiting. Diverticulitis or diverticulosis is typically a pain that can be felt in the left lower quadrant. It is related to herniation or outpouching of the walls of the sigmoid colon. Herniation creates the small pouches. These pouches can then fill with food particles or feces, causing inflammation and or bacteria to continue to increase, and then infection. So key history and physical findings are left lower quadrant pain, but occasionally we can see that in the right lower quadrant, chronic constipation, rarely diarrhea, fever, nausea, vomiting, and leukocytosis. Ulcerative colitis is another autoimmune disease. This can affect any area of the large intestine. This is one of the inflammatory bowel disorders along with Crohn's disease. But the difference is with ulcerative colitis, we only see it in the large colon, where Crohn's disease, it can affect any area of the GI tract. So this causes intermittent inflammation and ulceration of the colon mucosal lining. So it's not all of the layers of the GI tract, it's the colon mucosal lining. It does have exacerbations and remissions. Patient can have bloody or mucousy stools. Diagnostics to consider, we did discuss in a previous slide, CBC. You may want to check stool samples to rule out infectious causes, barium x-rays, but really colonoscopy is needed. Key history and physical findings: abdominal pain, usually left lower quadrant, diarrhea with blood or pus, rectal pain and bleeding. Other body systems can be affected, just as we see with Crohn's disease, weight loss, anemia, and then the colonoscopy is needed. Periumbilical or epigastric abnormal findings include abdominal aortic aneurysm. We do need to rule this out. When a patient has epigastric pain, it is life-threatening. Celiac disease is an autoimmune disorder with strong genetic predisposition. Ingestion of gluten damages the small intestinal wall. These patients are intolerant to gluten. Over time, immune reaction to gluten leads to malabsorption. So key history and physical findings include diarrhea, bloating, flatulence, fatigue, weight loss, iron deficiency, constipation, and depression. Peptic ulcer disease is inflammation and eventual ulceration of the stomach or duodenal lining. It is associated with chronic use of NSAIDs and H. pylori. Key history and physical findings. This can be asymptomatic in some people. It can cause epigastric pain, right upper quadrant or left upper quadrant pain. The pain is typically described as a gnawing or burning pain, which may radiate to the back. We see it worsen with food intake. So it says if it is a gastric ulcer, that's immediately following food intake. And if it's a duodenal ulcer, this can occur 2 to 5 hours after eating. These patients can have heartburn, belching, bloating, nausea, positive guaiac stool test, positive H. pylori, and endoscopy is needed in these patients. GERD or dyspepsia, so gastroesophageal reflux disease. It is the most common cause of epigastric pain, can be triggered with certain foods or medications. Food triggers include caffeine, alcohol, chocolate, fatty foods, tobacco. Other triggers include pregnancy and hiatal hernia. Key history and physical findings, a burning sensation in the chest, symptoms that are worse at night or when the patient lies down, difficulty swallowing, abdominal bloating, regurgitation, globus sensation, cough, hoarseness, worse with certain foods or medications, relieved with antacids, and these patients have negative H. pylori test. Irritable bowel syndrome is a functional bowel motility disorder. There are several types as per the Rome-4 classification system. It can cause intermittent, mild to severe abdominal pain with changes in your bowel movements. Unknown cause. The types include IBS predominant constipation, IBS predominant diarrhea, IBS with mixed bowel habits, or IBS unspecified. Key history and physical findings are recurrent abdominal pain at least 1 day a week in the last 3 months with altered bowel pattern. They can have diarrhea, constipation, or both. The bowel movements are during the day, not during the night. They can have bloating, gas. It is exacerbated with stress or emotions. Pain is relieved by having a bowel movement. And these patients too have exacerbations and remissions. Small bowel obstruction. This is normal blood flow of the intraluminal contents that is being interrupted, causing partial or full blockage of GI contents. Causes its abnormal intestinal physiology or mechanical obstruction. Most common causes post-op adhesions or hernias. So key history and physical findings for small bowel obstruction include abrupt onset of periumbilical pain, usually with nausea and vomiting, history of previous abdominal surgery, paroxysmal cramping, abdominal pain, abdominal distension, obstipation, dehydration, and abdominal inguinal hernias. Peritonitis is inflammation of the abdominal peritoneal lining resulting from a bacterial infection from perforation of the bowel or surgical contamination. Spontaneous bacterial peritonitis can be seen in advanced cirrhosis. This too is a medical emergency. Key history and physical findings include severe abdominal pain, history of advanced cirrhosis, fever, guarding, diffuse abdominal pain, rigidity and distension of the abdomen, rebound tenderness, leukocytosis, and altered mental status. So some abnormal GU findings include lower urinary tract infections, and this is when bacteria enter the lower urinary tract through the urethra, making lower UTIs more common than upper UTIs. Lower UTIs are of the bladder, which is cystitis, or urethra, which is urethritis. Incomplete bladder emptying increases the risk of this, and causes of this would include enlarged prostate, bladder or uterine prolapse, pregnancy. This provides the bacteria more opportunity to proliferate, and the most common organism seen is E. coli. Key history and physical findings: dysuria, urinary frequency and urgency, suprapubic pain, maybe low back pain, hematuria, turbid urine, low-grade fevers. Men can have urethral discharge and positive urine culture. And I had commented on a previous slide how the urethra is much shorter in women, making UTIs, the lower UTIs, much more common in women than men. Pyelonephritis is inflammation and infection of the upper urinary tract involving the renal pelvis and kidney. So it's more severe than lower UTIs. Bacteria can enter the kidney typically from untreated lower UTIs, and it can spread to sepsis if it's left untreated. Key history and physical findings include history of untreated lower UTI, sudden onset of systemic symptoms such as fever, chills, or malaise, urinary urgency, frequency, dysuria, flank pain, unilateral, abdominal pain, nausea, vomiting, gross hematuria, enlarged kidney, white blood cell casts on microscopy, which we did discuss a little earlier, positive urine culture, and pyelonephritis typically presents with a classic triad of symptoms of fever, unilateral flank pain, and nausea and vomiting, but patients do not have to have all three of these symptoms. Renal colic, urolithiasis, and uretolithiasis, severe abdominal flank pain from obstructing calculus, so renal or kidney stones that are within the urinary system. Renal stones can affect any part of the urinary tract, and signs depend on the size of the stones and the location. Pain results from dilatation, stretching, and spasms in the ureters. These are most often formed from calcium oxalate. Key history and physical findings are sudden onset of unilateral severe flank pain, intermittent colicky pain that can radiate to the lower abdomen, groin, or genitals, nausea, vomiting, dysuria, urinary frequency and urgency, low voided volumes, pink, red, or brown urine, tachycardia, and then the stones are seen upon imaging. Urinary incontinence, this is involuntary leakage of urine, mild to total. It can be mild, or patients can have total loss of their contents of their bladder. There are 4 types, so stress, overflow, urge, functional, or patients could have a mixture or mixed incontinence. Key physical findings, so with stress incontinence, key findings of the history are history of vaginal childbirth. Typically, these patients are overweight and have pelvic prolapse. What we see in physical findings are patients lose urine with sneezing, laughing, coughing, or jumping. With urge incontinence, patients have a history of neurodisease or injury or history of diabetes. These are more common. So they have urinary frequency and an intense urinary urgency immediately followed by involuntary urinary loss. So when they have to go, they have to go. Overflow is usually seen with benign prostatic hypertrophy, neurogenic bladder, or diabetes that can cause damage to the nerves. With overflow, the patients have constant or frequent dribbling of urine. And functional, we can see in patients who have dementia, disabilities related to mobility or medication. So these patients have physical or mental impairments that cause difficulty with them getting to the bathroom. So this is just the reference of your textbook. I know that we went through a lot during this PowerPoint. There is also a GI exam that you can watch that's posted in this week's content. So I hope you have found this helpful to you, and this will be topics that we'll discuss further in your APN courses.